I think what you're going to see over the next few years are rinses that have a beneficial effect to help dissolve the biofilm, not just try to rinse it away.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome, everybody, to another episode of A Tale of Two Hygienist, episode number 145. My name is Andrew.
My name is Michelle. Thanks for listening another week to our little podcast here.
Yes. And we apologize about the audio for last week. That was very uncharacteristic of us as of late. I mean, it's not uncharacteristic as a whole, but yeah, sorry about that. It's just, and then Michelle was traveling all week and we couldn't re-record it. So yeah, we did kind of publish it as it started. Chelsea, you did a great job with the interview section. This is why we need to have a studio here in Portland. And
hey, now
you and our new producer can come hang out here. We can just record 1,000 episodes all at once and be good.
1,000 episodes.
I mean,
sometimes we can barely even get this one done and not kill each other. So
that's true. So because we have a fantastic interview with Jason Luchtefeld,
yes,
previously of the Prism podcast and also Dental Town fame. And he was on our podcast before. He's a really amazing person. He really looks at research and just how to really deliver amazing patient care. So we have that coming up. We also wanted to read an iTunes review that we had, our newest one. And so this one came from K Squire. Catholic Square. Anyways, October 22nd. Well, there's she signs it and then there's a bye, whatever. Anyways, it says 5 stars. Hi. I've been listening to your podcast for about 2 years now. I felt I just needed to say thank you for all you do. It's funny. I sometimes read the title and think it may not be something that I'm really going to be interested in. However, like not reading a book that I buy, I somehow cannot ever skip over an episode. I'm always amazed that after each one, I think, wow, I didn't know that. I look forward to my morning ed sessions. I like that. Morning ed. Sessions, drive to work with my coffee, learning something new or refreshing and enhancing what I already knew. I arrive at work fully caffeinated with information I can use that very same day. Keeping current and being inspired by my colleagues has kept me burnout free. I've been doing this for 25 years now. Wow.
So impressive.
I love how much hygiene has to offer as it has changed dramatically over the years. Who would have thought I would be talking to my patients about sleep apnea or gut health during a dental prophylaxis? Thanks again for the way you two are able to come up with a diverse and fun way to keep current. I love it. K Squire RDH.
Oh my gosh.
Thank you.
It just makes my heart explode.
That was amazing.
Because all we ever wanted from this podcast was for people to just not be burned out, not feel like the monotony of our profession is killing them every time they clock in, just to be excited and be able to treat their patients with the most up-to-date information that they can get. I love it. It makes me so happy.
And Zirc really supports our quest for searching for new knowledge, and we appreciate their support of this podcast. Our promo this week is about the Essie Cushion. It's a new one. We haven't had this one yet.
So what's cool about this is that it's a cushion that goes on the end of your suction. It's just little blue.
I would say foam.
Foam-ish, but it's not foam. Yeah. It's not hard. So
foam adjacent.
Well, what's cool about this is that there's going to be some suctions that we use that give our patients that like tissue hickey. Like, you know what we're talking about when it sucks at the parotid gland or it grabs the floor of the mouth. Like this, it puts on the end. And so it still grabs all the water, but it just doesn't allow us to suck up the tissue pretty much with our slow speed. And it's really great.
And I think here's the other thing too, is we hear these noises all day long. It actually dampens the sound a little bit.
Oh, that's a good point too.
I remember I had this one doctor who always wanted me to leave the high evac on because it was a distraction for the patient. But at the end of the day, I had this little ringing in my left ear.
It's really bad for us.
This is going to help prevent that kind of noise fatigue that we feel a lot of the times.
If your doctor asks you to do that, get a sound machine instead. Like, my God.
A sleep sheep. That's what we got for the kids. A sleep sheep.
There you go. Yeah, so definitely try this. It's going to come in a 100-pack. And if you use the code TALESE, so TALESE, you get $5 off that 100-pack of the Essie Cushions.
And this episode's not going to disappoint you, by the way, because this is going to be all about mouth rinses and pH. And oh my gosh, what have we been telling our patients?
And it's going to be one of those that you think, like, why do I need to know this? And you're like, your mind's going to be like blown, like mine has been. And I've been harassing Jason anytime he posts something. And I've even had somebody send him mouthwash. I was like, try this one. But yes, you're going to really enjoy this one. Again, you might not have ever thought about this, and there's going to be more information to come as he begins to test other ones. And then we also mentioned a podcast by Ryan Nolan, and it's going to be the biofilm factor. You can find it on iTunes right now. I'm not really sure why it's not on the other ones, but it's only on iTunes, and I highly suggest it. And Jason was also on that one as well, so you should definitely check out that podcast. But you're going to enjoy this interview with the Jason Luchtefeld.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. This is your second time. It's been a hot second since you've been on the podcast.
It has been a while. What was that? VOD 1?
Yeah, that's right. Voices of Dentistry 1. So, and then you just said that you're about to be on Prism Podcast 100th episode coming up, which is awesome.
Yes. I can't believe that they're at 100 already. It seems like it was so not that long ago, but then I think back and that started in like 2013. So it's
because you guys y'all weren't like every week launching, right? It was kind of sporadic, and then you left, which I'm sad. Even though I love Clay, I was like, but you were great. You and Grant were great in the Prism podcast together.
Thank you.
And did I hear that you're going to be doing one for the equilibration? What is it? AES?
Yes. Yeah, that one's a little different in that it's really used as a way to offer CE to members as well as non-members and to highlight our annual meeting. I've only done 7 recordings. We've published 5 episodes. They're not real well promoted and are really we promote them to members and really have not promoted them to non-members, at least not yet very much. And they're centered, they've been a wide variety of topics from like total health stuff. We had Susan Maples. The most recent one was digital occlusion stuff with Bobby Supple. It was a really interesting thing. I learned a lot. And John Cranham, we just finished up and released this month.
Well, we brought you on this week because you did a post, maybe it was a few weeks ago, that I saw where you were testing pH of a bunch of different do we say mouthwash or mouth rinse? Does it matter? Is there a reason you say one versus the other?
Yeah, it's funny you say that because I would have said either one is fine, but as I type it, I always get a red line when I type mouth rinse. So I think mouth rinse is supposed to be 2 separate words and mouthwash is 1 word, but I'd have to call Webster's about that.
Get that Grammarly app, it'll tell you.
Exactly.
So we kind of can say that interchangeably, and there's not really a science behind one versus the other.
Correct.
Okay.
Not to me anyway.
So you were doing a pH test on a bunch. How many mouthwashes, rinses did you test?
I've done 12 so far.
Okay. What was the reason for doing that?
Well, there's a little bit of a backstory, and excuse me, I first got interested in it because I was at a lecture a couple years ago about hygiene, and they talked about the potential acidity of bottled water. And it was actually, I think, Kim Cooch who talked about it and has a story to share about that. And we did a little bit of testing in my office with that, but we were just using the strips, not an actual pH tester. So you can't say much about it. So we did a little poster thing for our patients that goes in the hygiene op, and it was always something we would mention, but never really that big a deal. then we're recommending all these different mouth rinses for people. And I'd started to see some stuff about alkaline mouth rinses, especially we recommend CTX4, which is like a over 10 pH and is a bleach-based mouth rinse, really strong. And so then I happen to be doing a discussion or podcast with Ryan Nolan, and he's talking about how, because I had brought up the water thing, and then he brought up mouth rinses and said, yeah, some of these mouth rinses are pretty acidic as well. And I said, oh, well, that's probably just so they have more fluoride uptake. I mean, that's what we were always kind of taught, was that's why you have that. And he goes, yeah, but that doesn't make any sense. And he went to explain the chemistry of it, and it started to click like, wow, like the acidity's there as a preservative more so than for a fluoride uptake effect, although you can get, so the research I've read on this was you can get a faster uptake of fluoride by having an acidic environment, but you can still get fluoride uptake in a neutral environment, and you can also speed up the fluoride uptake in an alkaline environment. So I don't know the chemistry behind that yet, but I'm slowly learning. So what that told me then was the acidity has a potential for being a problem, depending on how acidic it gets. So then that led me down that path to say, well, I wonder what these average mouth rinses are, as well as the ones we carry in our office. I mean, we have these ones that we tell people are special and fancy because we sell them in the office, but they're going and looking at Walmart. So I went to Walmart and dumped 10 mouth rinses in my basket. And
the checkout lady was like,
yeah,
you have some bad breath issues? What's going on?
Yeah, exactly. So that, led me back to the office, and I bought a very simple pH tester for like $30 off of Amazon. It has a calibration standard, and it's accurate to 0.01 units. And so I took a couple hours on a Saturday and set everything up, calibrated the thing, tested all the mouth rinses. That's what I posted then, was some of the pictures from that. I also tested a couple of the flavored waters that are out now and are very popular, like LaCroix. And I tested a beer.
Oh.
Yeah.
Did you test wine?
I did not test wine yet.
Can I request that?
You can. Yeah, so I tested 12 mouth rinses. And do you want to know what they were?
Yes.
I assumed you would, so I have this pulled up ready to tell you.
I could write them down. That's where it's going.
Yeah, so Crest Pro Health is one that gets a lot of press in my office. People have seen the advertisements and they use it, and we discourage it. And we always discourage it because we noticed people were getting more staining. And so
Stannis.
Yeah. And so that I tested 2 different Crest Pro Health formulas. One is called Pro Health Clinical, and one's the Pro Health Plain, and they are both quite acidic. I tested a generic Listerine that was alcohol-free. Epic, which is a mouth rinse I've really liked. They make a xylitol mouth rinse that I've actually been using myself off and on. I just like the flavor of it. It's a spearmint flavor. It's kind of nice, but it's no bueno. And then Colgate Peroxo I thought was going to be great because it's a peroxide-based rinse. Crest Scope Pero-X, which is a chlorhexidine, no-alcohol version from, is it Gum,
But
I think?
that wasn't over the counter, though, right?
Correct. That was out of my office stash.
Okay.
Act Restoring Closis, which is also something we stock in the office. You used to be able to buy this at Walmart, and I'm now told that you cannot anymore. I don't know why they've stopped carrying it, but
because the retail market is a mean
there you go.
biatch.
Yes. Also out of my stash, CTX3. So that's a carie-free product that is kind of tailored for kids. It's grape flavored. And then CTX4, which is also the carie-free product for severe caries risk people. And then TheraBreath, which is one I'd never heard of until I saw it in Walmart. So that is the 12. And kind of a spoiler alert, I said those almost in the order of their results.
Okay. So before we go into the results and things like that, tell me, because Trisha O'Hare in one of her courses that I've been to a few times, she did the litmus test with the strips, right? Where to test pH, and we tested like our coffee and our orange juice and our own saliva and then the water, and then we tested our saliva afterwards, and it was such a eye-opening experience. And the water was usually the most acidic out of them all. And so what is the accuracy of those strips? Because you said that those kind of aren't so accurate.
Yeah, so the strips, you're using a subjective judgment of color, right?
Ah, I see what you're saying. Okay.
So you and I could differ by 2 points. I mean, to me, it's, especially when you start talking about people being colorblind in different ways and all that, I think that the strips are nice for getting a general idea, like this is really acidic or this is really alkaline. But when you start trying to nail it down, like it's a 4 or a 5,
right?
It's not. It doesn't matter. And the fact that we know that we have specific numbers that cause damage. So under 5.5 is when you start to get enamel erosion. So that's kind of an important threshold number for me when I'm looking at a rinse or any product that somebody's going to be using on a regular basis. If it's a 6, even though that's considered acidic, I'm not going to stress out as much about it as if it's a 4.
Right. And did I hear correctly that like every pH point it drops after 5.5, it increases how like the
it's
the
not a linear scale. It's a logarithmic scale, and so the effects are sort of like compounded as you go either direction.
Okay. So Crest ended up being one of the most. Do you know what that was?
Yeah, the Crest Pro Health Clinical Formula, which you would think is their stronger one.
Yeah.
Was a 2.32.
Holy.
Which is awful. Like stomach acid
Ouch.
is like 3.3. I mean, it's awful. Yeah.
Okay. So
one thing that comes up, one argument that comes up a lot, and you may be able to speak to this with what you did in that class, and that is that people are only using this for 30 seconds to a minute once or twice a day. So what's the harm in that?
But what's the point in that?
Is it doing more good than harm or et cetera? So what I don't know yet is after using that rinse, how long does it take the saliva to buffer that?
To buffer it back up.
Exactly.
But why do you want to do that? I guess that's my question, because if we just learned that the chemistry says that you don't necessarily need to have acidity, because I think if I can go back, it was like you needed the acidic breakdown or demineralization so that you had that fluoride intake a little bit faster.
Yeah,
but
the article's from 1975, I think, when they first really found that out, and they did find like a 5 times faster fluoride uptake in that acidic environment. And so they were coming out with acidic toothpaste, which I haven't tested, but they're probably in that same realm, and acidic mouth rinses. So the problem is having 5 times greater fluoride uptake the solution that we need? Is it
right? Because
versus...
Shirley Kukowski has a really good quote that, dental disease isn't caused from a lack of fluoride.
Right.
So if you could control the pH, you're better off at controlling disease, dental disease, or caries at least, or probably a lot of dental disease. But but we're just creating. But there is a lot of variables. It sounds like, how long, how much will it take for your mouth to buffer it back up? But then you have to take into consideration dry mouth and types of saliva, I would imagine.
Yeah. Yeah, so somebody with no saliva is going to have a horrible time with it. And that may be why we see that they have more negative responses to more mouth rinses. Like, I've noticed that people with dry mouth hate Listerine. They have a hard time tolerating Listerine. Well, the alcohol in that is so drying, combined with their already dry mouth, that it kind of makes intuitive sense that they would have more of an issue. And so being able to counsel them that, you may want to look for a mouth rinse that has these things in it and not these things. That's more alkaline or neutral and not acidic. So that is certainly one. Another is the tissue response. So this is something else that was sort of new to me, that people that have sensitive gingiva or mucosa may also be more sensitive to the acidic rinses because they're harsh.
And when you say sensitive, are we talking like thinner biotypes? Are we talking severe inflammation?
Yeah, so on one spectrum would be people that have like pemphigoid and pemphigus. And I can't imagine what they deal with. I mean, I have a couple patients that have that, and one of them in particular just, it's every day is hard. Living life is hard because it's always, yeah. I mean, so we're actually experimenting now with her with some neutral mouth rinse, as well as a interesting antibiotic protocol. So doing the low dose doxycycline to try to help reduce the collagenase activity because of the so the breakdown of her tissues from the pemphigoid is just so severe that doing something to try to prevent that. And we're 1 month into that little experiment, and she thinks it might be helping a little. So we'll see.
Bless.
Anyway, that was a bit of a tangent there, but
a little digression, but a good one. And so we have that pemphigoid, and then would another one be biotype?
Yeah, I would think so. Although personally, I haven't noticed that certain biotypes are more sensitive than others. What I have noticed is that we get people that say, I can't use anything that has mint in it because it hurts. Or I can't use cinnamon because it burns my mouth. And so I wonder, is it that mint and cinnamon is burning their mouth, or is it the acidity of the rinse or paste that is burning their mouth? And so that's another one where, as I start to see these people now going forward, I'm going to start suggesting, hey, try this rinse. It's mint, but it's alkaline. And let's see how you do.
And which ones are considered alkaline? So what it starts at 7, it would be alkaline?
So 7's neutral. So I think for us, the biological range is like 6.5 to 7.5 is the neutral range. And then obviously lower numbers are acidic, higher numbers are alkaline. And really the majority of rinses right now are going to be acidic. There's only maybe a handful or less that are alkaline.
Wow. And
they're not, like, other than TheraBreath, they're not rinses you're going to find routinely in dental offices or in stores. And they're either brand new or they're custom product like the CTX4.
Did you try any of the dry mouth formulas?
Not yet. So I have a list going. I have 3 rinses that are in the mail. Thank you. And one of those is a molecular iodine rinse. One of those. Well, do you want to talk about the one you're sending?
I sent him Stella Life, which is a more wooier one. And if anyone has heard Jason's podcast, he really loves essential oils. Like, I actually woke up with a head cold today, and I made sure to up my essential oil. No, I'm kidding. I'm kidding. He loves the wooey side, but Stella Life is one of them. And then what else do you have?
So I have those 2, and then I have one that is based on elemental silver from Ryan Nolan. So his I've received, the elemental silver based one. So it's like a colloidal silver. So that goes way back. That even goes back to some of the stuff we're seeing now. Well, that was a weird statement, but the silver diamine fluoride is a silver based product, obviously, based on a lot of really old stuff that was effective. And colloidal silver is kind of in that same family where, depending on the formulation, it can be quite effective. Do you want to hear a funny story?
Always.
So I did a residency at a VA hospital. It was a GPR. So as part of that, we had to do grand rounds, sort of, and we had to do a paper and pick a topic and research it and then present it to the group of other residents from other hospitals that were in Denver. So I happen to have a patient that every time he came in, he carried a little jar, water bottle basically, of colloidal silver that he made himself at home. And he always offered it to me. I never took any. Always thought it was interesting but weird. And so that was what I did my research project on in my GPR, was colloidal silver. And this guy had an odd tint to his skin, but it wasn't bad. But he was starting. There's a name for that, and it escapes me right now off the top of my head. But he drank this stuff every day and was getting, the silver was building up basically, and it gets into the skin, and people turn blue. People look like Papa Smurf when they get severe enough. So he was using it for a really nonsense reason of trying to be healthy, whereas colloidal silver can have some beneficial effects topically. Wound healing. It can be antibacterial, antiviral, antifungal, depending upon, again, the formulation in there. So the silver ion has some pretty cool attributes to it. So anyway, Ryan Nolan is a dentist and chemist, and he has developed a mouth rinse based on the elemental silver that he is also still, I think, doing some antibacterial testing and all that kind of stuff on, but it has a pretty alkaline pH. Supposedly it's over 10. So I'll be testing that. Once I get everything in and all that arranged, I'll do some testing. It's probably going to be another week or two away, week and a half, something like that. And I'll do another round. I have one request to compare all the ACT formulations against each other.
I feel like you're just going to get a lot of requests at this point.
Yeah. I'm cool with that, though. It's fun, and I'm learning along the way.
I want you to do OraCare. Can I add that to the list?
Yeah, OraCare.
It's an activated chlorine dioxide like Closis, but it has xylitol in it. But it's a two-part system.
Yeah,
Because
I may
Closis
actually
has
have a
that
sample of
patent.
that in my office right now.
Yeah,
Is it
I
blue
think
and white? Blue and clear? It's like blue when you mix it?
Yeah, it's like a light, like a little tinted
Yeah.
color. Is it
Yep.
Argyria? How do you say that? ARGYRIA?
Yeah, it's when you turn blue.
Well, since we're talking about, like, I also want to go on the idea, because you said one of these had xylitol in it. Was it
The
Epic
Epic.
with xylitol? One thing that I was listening to somebody who does actually at Pulp Dent, I told you I had learned from one of their guys that creates a lot of the formulation at Pulp Dent, and one of the points he brought up is, a lot of people are claiming they have xylitol in their products, but none of it's a therapeutic benefit, like a therapeutic dose. And so it's more of marketing than anything. And so that's something that we have to also be cautious about. There's just a lot of variables, and sadly, marketing tends to win out more often than not.
So it does. It's frustrating. And I'm going to give another plug. There's an episode of the Prison Podcast where we discussed this with an FDA.
Did I miss this?
He was head of one of the departments that was involved with testing of some, it might have been supplements. But anyway, it's a cloudy area of so a company that does not want to have the requirements of a food product can just market their mouth rinse as a supplement, and it's a lot less stringent, and they can get over a lot of hurdles and not have to meet the same criteria. And so then that supplement, even though a supplement still is supposed to say what's on the label and be accurate, they are so underfunded with their ability to go out and police this that it won't happen unless somebody else tests it and then reports it, and then they go in and do their own testing. So it's a really frustrating area, which brings up the issue of if anything is classified as a supplement, then it's like up for grabs.
And it can be in their proprietary blend where they don't have to really give you all the details, right?
Yeah.
Which is scary. Because
Yeah.
I've actually learned, I think I did hear that Prison Podcast, and then I've also listened to one of my favorite shows is Adam Ruins Everything on True TV. Where have you ever seen those episodes?
I've heard of it. I've not seen any.
Well, he pretty much goes on these like rants on certain topics, and he references everything. Like, it pops up on the screen, his reference that he talks about certain things. And it can be like a topic, like he did one whole thing on like engagement to weddings to things like that, like how we've just been marketed to by all these companies. And one he did on supplements, and he was saying like, oh, they tested a lot of these supplement companies, and in their proprietary blend was a ton of sugar. But they didn't have to put that on the label because it was in their proprietary blend, and they don't have to do that. And so we have to be really careful when we direct our patients. And that's always been my soapbox with home care products, is that we can't just let our patients go wing it on the pharmacy aisle, because it could be harmful to them. And they are managing this medical disease that we're seeing in their mouth, but they're left to just go decide based on color and what's on sale in a lot of ways. And now that when you get this information about the mouthwash, it just makes me crazy. Like, I just can't believe that this is what our patients are left to just wing it.
Yeah.
And it's unhealthy for them. And in 2012, home care market was $5 billion, but we still have half of our people with disease. But $5 billion, billion is $1 billion. I can't even believe it.
Well, it's like you said earlier, the solution is not the lack of a product or a supplement. It goes a lot deeper than that.
For sure. So does it really come down just to pH control? Is that kind of where it all kind of lays and falls?
No.
No?
I can't say that. I've been influenced a lot by Kim Cooch. And
tell us who Kim is.
Okay, he is a dentist and researcher, I think. He founded Oral Biotech, which is the parent company of Caries.
Okay, so that's the CTX
yes.
3 and 4, which is kind of the sodium hypochlorite rinses.
Yeah, CTX3 does not have the bleach in it, but the CTX4 does. So that's why the numbers are there, because he talks about 5 factors involved in the caries process. And it's genetics, pH, saliva, bacteria, and a 5th one.
And a 5th one. That's good.
I think that was my Rick Perry impersonation there. Didn't he do that during like a presidential debate a few years ago? Forgot his 3 main points. Anyway.
And a 3rd one.
Yeah. So that's what CTX4 is it's targeting 4 out of the 5. You can't target genetics at this point, so it hits all the other 4. So it's hard to say that pH is the only thing, but the thing about pH is that the bacteria that do cause cavities are acid-loving bacteria. So if you are creating an environment that is acidic, then you're allowing those bacteria to flourish. And you're typically also doing other things that are reinforcing that with diet choices and stuff like that. So even if you did all alkaline drinks and rinses and toothpaste, you could still get cavities, because you're still going to be doing other things that are involved in that cavity process, especially if you have dry mouth, as you mentioned earlier, which is the number like that. If you have dry mouth, even if you've never had a cavity, you have dry mouth, you're a high risk for a future cavity. And that's just because of how much saliva is involved in reducing cavity risk. So that's the other thing I thought was awesome. Saliva is amazing. It has stuff in it so it's not only lubricating and it's neutralizing pH, but it's also super saturated with calcium and phosphate to help to rebuild teeth. And so it's awesome stuff. So if you don't have it,
the problem.
You've got problems.
It's the problem. Because where I was kind of going with that, I was curious how much maybe just tap water would neutralize the mouth, and if that is more beneficial than using something that is so low in pH.
Yeah. So the worst thing is frequency and duration. Mm-hmm. So, I mean, that gets back to just being realistic. You know, if somebody loves Crest Pro Health and they're not showing detrimental signs of caries or anything from its use, I'm not going to discourage the use.
Right.
But if they have other things going on and the ill effects, then I'm going to be talking about all the things I can to try to tip the scales in their favor. So it comes down to working with each individual patient on kind of their own baby steps of getting from high risk to low risk. And the people that are already low risk or no risk, they're 50 years old, never had a cavity. Well, I mean, they don't need my advice.
Right. So we're talking a lot about caries, though. What is this pH issue with rinses? How does that fall with the other pathogens like AA and PG?
Yeah, that's a great question that I don't know yet how those are involved. So I just got a paper that talks about the comparison of chlorhexidine to CTX4.
Okay.
So CTX4 is billed for caries patients. However, when you look at what's in it, you're like, oh, this must kill all kinds of bugs. So I know people that have used it for perio patients as well. But it turns out it is not as effective as chlorhexidine on the perio bugs.
That's interesting because they even say that chlorhexidine isn't that useful for periopathogens anyway.
Yeah. But it has substantivity.
Right.
Which a lot of rinses don't.
Don't have.
Yeah. So that's the other thing is what ingredients in there are necessary to allow that rinse to do all it needs to do for the length of time you want it to do it for. And in order to have that, does it have to be acidic? Can it be alkaline? And I don't know the answer to that yet. It just means that we have more things to think about with this than just pH.
Right. So CTX or caries free, you said the CTX4 has a sodium hyperchlorite.
Yes.
So have you tested just like the bleach water mixture that I know that USC has a concoction that they recommend?
I've not tested that yet. I have recommended to people to do a 1 to 10 bleach solution in their water pick. Mm-hmm. If they're looking for something cheap and easy, that or peroxide. But I've not tested that dilution yet for pH status.
I'm curious because that is something that I do recommend to a lot of my well, it used to be low-income patients, but now I just kind of anybody who's got some pretty serious perio conditions.
Yeah. So the other thing that recently came up was using whitening trays with a low dose of whitening gel, which is peroxide or carbamide peroxide, and using that in perio patients or caries risk patients as long as they don't have tooth sensitivity.
Well, that's pretty much what the perio
bugs.
protect trays are, right? They're
exactly.
They're like a peroxide solution, but kind of driven down into those very particular deeper sites, right?
Yeah, they're not a sponsor of your podcast, are they?
They are not.
Okay, good. So if they're ridiculously expensive, and if you need to remake it, they recharge you, and I mean, it's to me not something I'll use.
Well, and I hear it works, but the patient compliance is pretty low. So then, of course, it doesn't work. But it works on the patients that are compliant with it. So you did a generic Listerine, but not a regular Listerine? Any particular reason? And you said, was that alcohol-free?
Yes.
How about the one with alcohol?
Yeah. At this point, it was just a random selection on my part. Like, I mean, have you gone to the mouth rinse aisle lately?
It's insane.
And looked?
You would have to take out like a small loan to get all.
Well, they've got like neon lights. It's like you walk into a disco, all the different colors and products, and I mean, it's crazy. So, and it was also like some of them are not cheap. So I think it was the Walmart brand Equate. So at that point, I had already loaded up like 10 in my cart. I was like, man, these are like $6 a piece. I'm going to grab the one that's $1.
But you know what? That's how most people are going to be buying it. So they're going to get that Equate brand, which is what, the second on your list. Is that right?
Yeah. Yeah.
What was that pH?
2.9.
Oh, bless. And that was alcohol free.
Yeah.
Now, is there any because there was this big fuss over alcohol rinses causing or being carcinogenic at one point, but they kind of debunked that in a way, unless people were like rinsing 15 times a day or something like that. Is there still any issues with the tissue when we are rinsing with high alcohol rinses?
So you're going to get my opinion on this,
Okay.
not the latest and greatest from any research. And that is that, so I think originally that came out because they found alcoholics had higher incidence of cancers of a variety of types, and it was kind of translated down into products that had alcohol. And so, like you just said, for a mouth rinse that has a high alcohol, and the classic Listerine has like 30 some percent, I think it's really pretty high. Even Scope, I think, is over 20%. And so the frequency becomes the issue. And if you're using it once a day for 30 to 60 seconds, I don't think it's probably going to give you cancer, unless you're also having a six-pack every day. And
Well, I don't know. Andrew, does any of your dentists do that? Like, I know more dentists that rinse with Listerine. Like, they walk into the room with their patient, do like a little splash of Listerine, rinse and a spit, as they're like, and I'm like, they probably do it 25 times a day. And I'm like, that is not going to be good for you over time.
well, and we all know all dentists are also alcoholics, so
It's probably their hygienist driving them there.
it's just right. Glad you said that, not me.
It's all right. It's mutual because the dentists are. That's why I drink wine. I've worked with too many
Right.
dentists over years.
Exactly. Touche.
So, any of those rinses proposed subgingival? Do you see any benefit using them subgingivally?
Well, only for the kill effect, but no.
No.
And
There's
that
no
becomes an
science
issue
really to
too.
support it, though. That's what I keep going back to. But people love a chlorhexidine rinse subgingival.
Yeah, so people like to charge for it too. So that
There's
affects
that.
decision making sometimes.
That's a good point.
So I attempted that, or my hygienist attempted that for a while to do. The hygienist had gone to a lecture. I don't remember who it was, but she had this nice protocol for perio patients that included a subgingival irrigation of povidone and iodine. And so they were actually doing that on a few patients. And we found that patients healed, but couldn't say whether it was better or worse than what we were already doing. And we even had some people that we sent them home with a syringe because they had a molar that had recession and was just really hard to clean. We were like, yeah, just use this in there. And they'd come back after like a week and be like, yeah, I'm not doing this. Like, it's a mess. I ruined a shirt. It's just not feasible. You said that earlier about, people, how much do you give people to do at home? And are they really going to do it? And it's really about making things simple for them. So, no, I don't see any benefit. I love a water pick for some people, but I wouldn't consider that a subgingival irrigator unless they're really getting after it.
Yeah, I guess they could use like the tips that go into the sulcus, but that at that point is more about the introducing this oxygenated water into an environment that doesn't want oxygen, and I think that's where the reduction in inflammation comes from. Plus, it also creates that pulsation, which creates that suction effect within the tissue because it's doing that back. I don't know what that suction effect is called. I forget, but there's a lot to do with that. That's not so much about chemicals and chemotherapeutics in that way.
But then just the flushing action is going to be effective, possibly. And then the disruption of the biofilm to some degree is going to have a beneficial effect.
To some degree.
Yeah.
So I'm not going to say much because there's some people that might come murder me in my sleep. I feel there's a mob in our dental
The biofilm effect, though, is, I think, something that's important because I think what you're going to see over the next few years are rinses that have a beneficial effect to help dissolve the biofilm, not just try to rinse it away. And I think that's going to be an important differentiation in effectiveness over time.
But what do you think that that's going to do to good bacteria?
I don't know. It may not be a good thing, but I think that's the thing is none of the things we have right now are targeted specifically at only the bad bacteria. If you look at anything that's killing bugs, it's killing all the bugs. So and that's part of the problem is I never got into it, but there are people that maybe you guys do this or have at one time. Do you ever pull microscope slides and look at the bacteria culture on people?
I know Alan Mead is real big on that, or at least like swabbing people's mouth and putting it up on a microscope. I haven't done that since like micro.
Right. Yeah, so that to me has potential just because you're then maybe a little more aware of the specific bugs, but I don't know that we have any targeted means to hit those bugs. The really interesting thing would be if you find spirochetes.
Yeah.
Because spirochetes are tough badasses. And
I just heard like on actually Ryan's podcast, the biofilm factor, that like they almost like curl up almost and look like cocci. Is that right?
Yeah.
And then and like protect themselves a little bit.
Exactly.
Which is crazy. But then that's what is also like your spirochete infections are like syphilis and Lyme's disease.
Yeah.
Like pretty nasty infections. So that's crazy. But I'm thinking too, because this whole idea of dissolving the biofilm, because it's not, I'd rather do a microscope to see what it is, because not all biofilm is bad. It's just a lot of it, but it's not always, the quality isn't poor. It's just a high quantity rate. So do we want to dissolve it if it's not like filled with pathogens that are going to harm us? But I'm sure somebody smarter than me will figure that out.
Yeah, I think it would be important to look at who that's used on. So I think if you have a healthy person, you're not necessarily recommending these adjuncts. Compared to somebody that has severe caries or severe perio, you almost need to hit them with this stuff.
But I unfortunately think that our profession does a very generalized recommendation, and just because they have a high amount of biofilm, they would just make very broad recommendations versus tailoring it to the individual and their particular disease and what type of pathogens they're fighting. People who don't really think into it a lot, and they just like to make these broad strokes with recommendations.
Yeah, well, that's always going to be the case. There's a reason people like cookbooks.
This is true. That is true. It's a problem. They want a recipe.
Yeah. And even then, they don't always follow it.
That's true, too. So, Andrew, you're so quiet over there.
I'm just waiting for him to circle back to LaCroix because my wife drinks LaCroix a lot, and I didn't remember.
Oh, yeah, let's tap those. Let's talk about the beverages.
Yeah, I was pretty upset, actually, at the numbers that I got from LaCroix and Hint. So I've been pretty horny about the Hint water because it's 0 calorie and it's they use like fruit essences, so people love it, and I like how it tastes. So I really, really wanted it to be neutral, and it wasn't. The LaCroix, I don't have the data right in front of me, but it was right around 4. And the Hint was right in that same range, maybe 4.2, 4.3. So they were not good. And the beer that I tested was 4.5. So that was also disappointing.
Maybe I don't want you to test wine. Don't do it.
Right. You probably don't.
I probably don't. But this all goes back to, again, frequency, right? Like, so if you're drinking that in one, 10-minute period, is it really that big of a deal?
Yeah, the problem for me was I was testing the water because, well, the how do you say it?
Le Carreau.
Blah,
Le
blah,
Carreau.
blah.
La, la,
That's
la.
how you say it.
Somebody French, tell us.
Yeah. So that was something that I tested because it's become so popular that people are using that to replace their soda. Mm-hmm. So you think, oh, awesome. And it is. It's better because you don't have the sugar attack, but it's still an acid attack. So even though people are sipping those all day.
They're
not
right.
just chugging them with a meal. Same with the hint water. Like I brought that into my office for my staff because I had a couple staff that were not drinking things that I would consider are very good. And I want to try to promote more beneficial things. And so I've offered to bring that in and have it available for them. But then I found out it's acidic. So it's just a constant battle. I just found one. I don't know how you pronounce it. It's spelled like Qure. It is an alkaline water with flavoring. So it's a cucumber mint alkaline water, pH of like 9.5. So I just got it in the office. I think it arrived Friday. So I'm going to try that out and see how that does. But yeah, trying to find things that are going to be somewhat safe for people to actually use to replace a bad habit versus trying to turn it off.
Right. Which is huge. It's huge for that behavior modification. But what about like bottled water? Because that's what you hear a lot of too. And then you're also seeing the alkaline water, and it just kind of makes me question, is it actually alkaline?
Right. I also got some Essentia, which they sell at Whole Foods. So that's a 9.5 as well, or maybe 10.5. It's up there. And so I'm going to test that
And that's
in my next go round.
bottled water?
Yeah, just a bottled water.
Okay.
Yeah, so the interesting thing there, this is getting off topic a little bit. I wonder then, though, if we're drinking alkaline, what's that doing in the stomach? Is it going to make the stomach produce more acid to buffer that
To
pH?
buffer it?
Or not? And is it going to have a negative effect on people with like GERD and stuff like that?
Like
Or is
to
it gonna be
turn
better?
on those proton pumps?
Yeah, I don't know.
That's a good point too.
Yeah,
Who's going to do that research? We need to find somebody for that now.
I know. Need a GI doc. Get a GI doc on here, would you?
I would love to, because I want to talk about SIBO and the fact that xylitol can really trigger that, or at least increase its issues.
Yeah.
I heard that at one of the AOSH meetings, which I found interesting, because I mean, our mouth is the first part of digestion, so it would make sense. Have you tried, I got this right here. Alka White?
Yeah, I just got some.
Did you? Oh,
Yeah.
good. I'm so excited. I'm going to like harass you with this, because this does have sodium bicarb, xylitol, coconut powder, tea tree, and peppermint.
Yeah.
So right up your holistic wooey alley there.
Yeah, so a big part of that for me is it a therapeutic dosage
Amount,
of stuff?
yeah.
And really that's being promoted as alkaline, pH neutralizing. I mean,
Right.
it comes with pH strips in there, right? Have you opened it? They're in there. There's a little bag of pH strips. What they want you to do is test your saliva beforehand and then use one of their tablets and then test your saliva afterwards to say, oh, look, your pH is better. So I think that's great. So if people want to use that after a meal, then go for it. It doesn't necessarily replace toothpaste for me, depending on the person and what they're using it for. But I think it would be something fine if people want to use it. I'm not against it. I've tried it and break a tablet in half and just put it in your mouth and let it
chew it up?
bubble and chew
Oh.
it. Yeah, and then swish it and then spit it out. And yeah, it's fun. Slight minty flavor. It's not bad. The bubbling's weird at first, but
So this would be a topic for another time, since we are probably at our limit, and I'm sure Andrew and our producer is real annoyed with me right now.
yeah, Andrew's
I haven't
falling
said
asleep.
a word actually about that. I am not. Although it is getting dark around here.
I know we fell back an hour with our time today, but I am definitely curious in like the realm of toothpaste, because you made a really excellent point on Ryan's podcast about the fact that mint is a distraction for a lot of people, and it foams and it gives us this false sense of security that our mouth is clean. And then people sometimes, I don't brush my teeth with very minty things. And so when I do test a toothpaste and it is more minty, it is very intense. And it almost like numbs the tissue. So you don't know where you're brushing. You don't know how clean everything is. And it's just a false sense of hope of a clean mouth.
Yeah. We need more mindful brushing.
Yes. Well, Trisha O'Hare has the whole dry brushing. Like, don't brush your teeth with the toothpaste first. Brush to brush, and then throw that in there for its therapeutic benefits for xylitol or fluoride or whatever.
Yeah.
And that'd be the end of it. But anyway, we'll talk about that at another time.
Sounds good. And I'll shoot you an email when I get my latest results, and you can just share them with your audience if you feel
Appreciate
like it.
it. Oh,
And,
I'm sure I will.
Yeah.
Awesome. Well, how can people find you?
It's just me, my name on Twitter or Facebook or Instagram, or you can email me, jluchte@hotmail.com.
Thanks so much for coming on.
Yeah, it was fun.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
This story time is in regards to mouth rinse, but not necessarily the pH. I've been using this systematic review for a while as like my go-to regarding chlorhexidine and subgingival irrigants and things like that. It is a 2018 systematic review brought to you by Periodontology 2000, volume 76, and it's titled Patient Self-Care of Periodontal Pocket Infections. So it goes through, it's a pretty long article, so I'm just going to take like some clips out of it. This section is antiseptic rinses to control subgingival biofilm. Antimicrobial agents can be used to support mechanical biofilm management. Whilst they can be directly applied subgingivally, their effect on subgingival biofilm has major restrictions, such as subgingival biofilm, which consists of adherent and floating bacteria, harbors more anaerobes than supragingival biofilm. In periodontal pockets, it is more difficult for antibacterial agents to reach their target site and or to sustain a concentration high enough to affect the biofilm. Gingival curvicular fluid flow increases with clinical signs of inflammation and washes out antibacterial agents within a short period of time, thus limiting their subgingival effect, and in periodontal pockets, antibacterial agents can be inactivated. This is especially true of chlorhexidine. You heard it here, guys. This is especially true of chlorhexidine. It's not the end-all be-all. Back to this. Although chlorhexidine is currently the most efficient anti-plaque and anti-gingivitis agent available and is generally accepted as the gold standard, it has been shown to be inactivated by blood and serum. Therefore, the effects of chlorhexidine observed in the supragingival environment cannot simply be extrapolated to the supragingiva. You hear this? Just because it works supragingivally does not mean it works subgingivally. Sorry. Moving on. Subgingival irrigation. Most approaches for irrigation or lavage of pockets are administered professionally and aim to flush away unattached plaque or bacteria coronal to the gingival margin, to dilute plaque toxicity, and to interfere with subgingival biofilm maturation in order to directly reduce the pocket microflora. However, as mentioned above, such approaches also create the risk of forcing bacteria into the pocket or causing a bacteremia. Larner and Greenstein identified calculus as a result of lack of scaling and root planing before irrigation, irrigator tip design, side or end port cannula, and irrigation force to minimize the potential of projecting bacteria into the tissues as factors affecting drug delivery. However, they could demonstrate, under optimal conditions, penetration of drug of 90% into the pocket 6 millimeters and up to 80% in pockets of 6.5 to 10.5 millimeters. Several studies could not show significant differences between control solutions, sodium chloride, and other antibacterial agents like chlorhexidine or providone iodine, when used for subgingival irrigation during scaling and root planing. Recently, the authors of an animal study in rats emphasize that they agree with the position of the American Academy of Periodontology. They state that there is insufficient evidence to indicate the routine use of subgingival irrigation as adjunctive to periodontal treatment. They found no statistical significant difference regarding bone support and epithelial migration between the group treated with scaling and groups treated additionally with subgingival irrigation. Even daily patient-administered chlorhexidine, 2%, irrigation of deep pockets for 24 weeks after one episode of root planing did not enhance the effects compared with non-irrigated controls. Studies yielding significant reductions of bacteria, even as monotherapy with chlorhexidine, stannous fluorides, or providone iodine, and clinical parameters looking at plaque and bleeding indices often resulted in the quick rebound to baseline values within 1 to 8 weeks and no response to tissue invasion organisms. So I think this stuff is interesting. I'm going to go over some other antibacterial agents in home care products. So as gingivitis is caused by an inflammation provoked by metabolic products of bacteria, it is possible to affect the growth and metabolism of bacteria in oral biofilms biochemically. In dentistry, compounds that are able to reduce the amount or vitality of dental biofilms as a result of an imminent antibacterial action are a valuable option in dental prevention, and they can be incorporated into toothpaste and mouth rinses. Just FYI, this has mouth rinse as one word. Toothpaste can, at first sight, ideally combine mechanical and chemical biofilm control and also serve in the prevention of caries and gingivitis. While fluorides represent the most well-known and most effective substances in caries prophylaxis, other additives have proven antibacterial effects. There are, however, some limitations. The composition of toothpaste is very complex, and inactivation of antibacterial compounds is possible. Most antibacterial agents are per se more soluble in water than in toothpaste formulations, and antibacterial agents are strongly diluted during toothbrushing because surfactants in toothpaste favor foaming. Another limiting factor is the amount of toothpaste used during brushing and rinsing. While normally 1.5 grams of toothpaste is used for brushing, rinsing is generally performed with about 10 to 20 milliliters, the 10-fold amount that should be used for brushing. In clinical studies, the additional antibacterial effect of toothpaste is very difficult to isolate from its mechanical cleaning effect. To overcome this obstacle, the 4-day plaque regrowth study design, which has been used in numerous investigations, does not use any mechanical plaque removal measures. It can rather be described as an established method used for testing and the antibacterial and plaque-inhibiting effects of an oral hygiene product without disrupting the plaque through toothbrushing. Additional use of antibacterial mouth rinses. Some authors refer to the fact that mechanical cleaning procedures can only remove biofilms present on the tooth surfaces, which only represent 25% of the oral cavity. Most regions practically did not benefit from mechanical oral hygiene by brushing, flossing, or other interdental devices. This, as well as the above-mentioned limitation of antibacterial agents in toothpaste, would favor the use of antibacterial mouth rinses because they can spread throughout the whole oral cavity and reach niches such as the tongue and tonsils. Unfortunately, in deep pockets, only a very limited effect through patient-administered irrigation was found. A recent consensus paper states additional improvements with the use of mouth rinses in gingival inflammation and plaque levels, which are larger than if delivered by dentifrice only. The paper recommends adjunctive use of mouth rinses when improvements in plaque control are required, but also indicates that mouth rinsing represents an additional step in an individual's oral hygiene routine. Chlorhexidine has some well-known side effects, including, most commonly, yellow, brown, or black staining of the teeth, tongue, and restorations. Although these extrinsic stains are mostly removed by a professional tooth cleaning, more and more dentists and patients refuse the use of chlorhexidine when it is indicated, fearing side effects. There are many professionals who disregard the 40 years of clinical use of this agent and rather focus on the risk of staining and toxicity and the possibility of bacterial resistance. However, so far, toxicity and bacterial resistance has not been proven clinically for chlorhexidine. Certain wound toxicity has been shown in vitro, but the opposite is apparent in the clinical literature. It should be borne in mind that chlorhexidine is inactivated by blood and serum proteins, and therefore not only is it not indicated for use during oral surgery, it would not be sensible to use it in this situation. Moreover, chlorhexidine is not a treatment option to kill periodontal microorganisms. Rather, it is indicated when supragingival biofilm growth, which cannot be completely removed mechanically, needs to be interrupted. So guys, what that is saying for you is that chlorhexidine is not indicated for subgingival use. There's not been any science to prove that providone, iodine, and chlorhexidine are effective in subgingival areas, and it is actually not even recommended for around bleeding. It has only been FDA approved for supragingival uses. It has never been FDA approved for periodontal pathogens. So take that and stop irrigating post non-surgical. It's just not going to work. The end. So I don't know about you, audience, but I know Andrew's mind was blown in this.
It was good. Well, I mean, Jason said later on, he's like, Andrew, you could have talked more. I'm like, how can I? Like, you guys are doing such a good job. It was so amazing. I literally was recommending certain things I shouldn't have been recommending. And also to clarify, I don't know if we ever circled back really. Jason's really looking at a lot of things still. He's trying to figure out, is being too acidic, being too basic, what's really the culprit? How can we really like make a definitive thing for our patients? And also something, I can't remember if we said this on or off air, but he was mentioning like we really need to make sure that we're being very centered on our patients. People that have high caries risk need certain things. People that are perfectly healthy maybe don't need certain things also. So you need to have some clinical judgment and use your brains.
Critical thinkers.
And don't just let it be, a one size fits all, especially with mouth rinses in general.
Yeah, totally agree. And I want to do one on toothpaste one day. I want to do one on toothbrushes because these are just very simple things, and we make these very broad recommendations to our patients, but this is literally what they use every single day, hopefully. And this can make or break them in some cases. In some cases, maybe not your average everyday patient that could never brush and never rinse and never have a cavity, then yeah. But that's not the average. That's more the exception to the rule for sure. So I'm excited about maybe going down that rabbit hole with our home care products in the future.
Yeah. So so thanks a lot to Jason for delivering on that.
Yes. Awesome job.
And I hope you guys all learned something.
And we hope you guys continue to like us and share these posts. Continue to tell your friends about the podcast. Don't forget, if you haven't liked us or found us or followed us or whatever that means on Instagram, do that at A Tale of Two Hygienists. And we are also now on YouTube, guys. So if you want to listen on your desktop at YouTube, you won't see the video yet because there's more of that to come. 2019 is going to be... We're going to be doing some fun things, but you can listen to the podcast now on YouTube, Spotify. We're working on Alexa, y'all. She's not that easy, but we're getting there. 2019.
There's an Alexa girl out there being like, wait a second.
Why are you talking about
me in this? Or are they talking about...
Oh, can you imagine the girl's name Alexa these days?
She's like, you're right. I'm not easy. Anyways, sorry.
Oh,
Continue on.
all I can see now is like a mom yelling at her daughter named Alexa and like, what can I do for you? Like, whatever she says. Anyway, but you can also go to ataleoftwohygienists.com. Please go ahead and subscribe there because, again, we're not doing anything currently with those emails, but one day we are going to have wonderful things that we send out to you. And if you have any questions, you're welcome to shoot us an email at ataleoftwohygienist@gmail.com or through Facebook Messenger or Instagram direct messenger. And I even got a comment the other day on our YouTube page asking a question about a podcast. So I get notifications on that, guys. So if that's where you want to talk to us, that's fine too. But we hope you enjoyed this episode, and I hope you come back next week.
All right. See you guys then.
Bye, y'all.
Bye.